Hello everyone, I am Muhammad Ali Hashim, F1 hemato-oncologist. The moderator of my presentation is Professor Bassam Matar. Today we will discuss together the adjuvant treatment in ACC. First, I will start with the NCCN guideline recommendation for ACC. When we suspect ACC, we should do PET scan, seated chest without IV contrast, CT or MRI abdominal pelvis with IV contrast. Based on the result of this image, we have two probabilities, either resectable or unresectable. If resectable, we go to open adrenalectomy. So as we said before, in case of localized disease, open adrenalectomy is the recommended approach. Why not laparo? Simply because the studies show lower recurrence rate with open approach. After surgery, we consider adjuvant mitotain with or without external beam radiation if we have high local recurrence risk. Pay attention, what does mean category 3 in NCCN guideline? There is major NCCN disagreement that the intervention is appropriate. So in next few slides, we will discuss together the latest data available on the adjuvant therapy in ACC. Staging our patient is T3, N0, M0, so is stage 3. The decision to give adjuvant treatment will depend on the risk of recurrence. So we categorize our patient as low risk, high risk, very high risk. Who is categorized as low risk? Patient with stage 1 to 3 disease, patient with R0 resection, if Ki67 less than 10. The 5-year relapse-free survival in low-risk patient is 75%. What the optimal adjuvant treatment? We suggest observation. Based on the Adjuvant study, which was published in the Journal of the Endocrine Society on May 3, 2021, where 91 patients randomly divided into two groups. The first received 2 years of adjuvant mitotain, while the second group underwent observation. This study failed to demonstrate significant improvement in relapse-free survival or overall survival. Who is categorized as high risk? If we have histologically high-grade disease, Ki67 between 10 and 20, if we have incomplete resection, if we have intraoperative capsule rupture, large or low-grade tumor with vascular or capsular invasion. What should we do? We suggest the use of adjuvant mitotain. As we mentioned in the NCCN guideline, adjuvant mitotain is a category 3. Why? Because data about adjuvant mitotain is mixed, with some study demonstrating its benefit, while others show no significant advantages. The best available evidence that adjuvant mitotain improve outcome come from retrospective analysis published on 7 June 2007 in the New England Journal, where 177 patients from 8 centers in Italy and 47 centers in Germany between 1985 and 2005 divided into two groups. 47 Italian patients, which is the mitotain group, whereas 55 Italian patients as control one group and 75 Germany patients as control group 2 didn't receive adjuvant treatment after surgery. As we show, this chart showing mitotain treatment was associated with significant longer relapse-free survival and longer median overall survival. So adjuvant mitotain may prolong recurrence-free survival in patients with radical resected ACC. We categorized as very high risk if we have Ki-67 more than 20 or extensive vascular invasion. What is the optimal adjuvant treatment? We can add cisplatin to mitotain or cis-based chemotherapy to mitotain. Based on the study that was published on the British Journal of Cancer on October 2021, where 31 patients received chemo plus mitotain compared with observation group, this chart shows significant improvement in relapse-free survival and overall survival in adjuvant chemotherapy group. About adjuvant radiation therapy, they suggest adding radiation therapy to mitotain group. We should give adjuvant radiotherapy for all patients with incomplete resection or R1 or R2 or uncertain margin, and for those with stage 3 disease. We can give radiotherapy for some other condition, as if we have patient with complete resection R0 with tumor size more than 8 centimeter, if we have Ki-67 more than 1, for patients who have intraoperative tumor capsule rupture. In the context of adjuvant radiation therapy, only a single study have shown a significant benefit in overall survival. They recommend starting radiotherapy no later than 3 months after surgery. One of the studies that was published in the Journal of Clinical Endocrinology, Metabolism on August 2006, where 14 patients received adjuvant radio while other 14 patients underwent observation. In this chart, first chart talk about local recurrence, where the second chart talk about recurrence in general, distant and local. In the first chart, from 14 patients in radiotherapy group, 2 of patients had local recurrence, whereas 11 patients in control group had local recurrence. In contrast, we have 9 patients had recurrence in general, local and distant. And as we mentioned before, we have 11 patients had recurrence. So according to this data, radiotherapy is effective in reducing the high rate of local recurrence in ACC, despite neither disease-free survival or overall survival were significantly better in irradiated patient. Take-home message: Ki-67 was one of the most important prognostic factors. The median relapse-free survival duration in patients with Ki-67 less than 10 is 53 months, and the median overall survival is 181. If Ki-67 is more than 20, so the median relapse-free survival decreased to 9 months, and the median overall survival decreased to 42 months. So, categorize your patient: if low risk, observation; if high risk, adjuvant mitotain; if very high risk, adjuvant chemo plus mitotain. Some patients may benefit to added radiotherapy to delay or prevent local recurrence. Any question?